working in the same position.
Okay. When does it bother you? When does your shoulder bother you? Does it bother you when you're reaching overhead?
It's just very tight, and then I don't do the reaching out that. But when I work, it just pains after long standing position, the steady position.
Okay. So it doesn't bother you to go behind your back or reach across your body or overhead?
I guess I do, but I don't do that type of movement. But yes, I do.
Say you're at the house and you're putting dishes away. Does it bother you to reach overhead?
Yes.
Yeah? Okay.
Yeah.
How about if you're washing your back or trying to tuck in your shirt? Does that bother you?
Yes.
Yeah? Okay, so all those positions bother you. So those are important clues to us, depending upon which movement it is, to what is actually causing your shoulder pain. So we're going to go through some of that today as we work through this worksheet to determine exactly what is causing your type of pain. And we'll get about 90% of what causes your pain based off of what you tell us and based off of what bothers you. The other 10% of what's causing your shoulder pain, we will determine based off of specific tests that we would do on the table. And that basically tells us exactly what's going on. And then if we took an x-ray, a radiograph, or an MRI, that just verifies what you told us and what we found out on the table. Your goal is never to be on that table, right? Right. Okay. So thank you for sharing your symptoms and your issues with us. So what we're going to talk about today, are you familiar with the rotator cuff?
Not really.
No. Okay. All right. So the rotator cuff is a group of 4 muscles, and it runs basically from your shoulder blade. So you got 3 of them. Oh man, again, we're going to try to draw this here. But your shoulder blade is going to kind of look like this right here. You're going to have a little hook that kind of comes over towards the front of it right there. And then your shoulder bone is going to come in right here. Boom. And then boom. Okay? Now, so that's the back side of your shoulder blade. Sorry, I've got my back to you here. But you have one little muscle that's going to come right through here, and it's actually going to come right across and attach right down there. Okay? That muscle is called your supraspinatus. Fancy, right? Supra just means on top of, and so that's your supraspinatus. Then we're going to come down right below that line here, and you have another muscle. And it comes over and attaches over here, and it's called your infraspinatus. Okay? Now you also have another little muscle. I'm going to try to find another color here, and it comes over and attaches right there. So it attaches in a little bit of a different spot right there. And that one's called your teres minor. It's a little small, and obviously this isn't to scale, but it's a little bit of a smaller muscle. Okay? Then if we come to the front side of it, so if I drew this same picture here, coming into this direction here, now this is the back side, and this is the front. Now we have another muscle that comes right across through here and attaches right here, and it actually causes a different motion as well. So it's 4 muscles, okay? So on our sheet there, we can talk a little bit about these. So those 4 muscles that run from the shoulder blade into the top arm of your bone, which we talked about. All of these muscles try to keep this bone here, our arm bone, fancy word, humerus, the humerus bone, centered inside our shoulder blade. So they all have to work together in order to do that. If we happen to have a tear in one of them, then that will actually throw the mechanics off, and it'll make this bone here raise up a little bit, or it'll make it rotate forward a little bit, or rotate backwards a little bit. And our goal with that shoulder bone and those shoulder muscles is to make sure they're all working together to keep it inside here. Now, you may have a family member or a friend that you know that has shoulder pain, and sometimes you may see them when they raise their arm up in the air, they may try to do this motion right here. So they're actually using some other muscles to try to raise their arm in the air, but it'll never happen because the mechanics will be thrown off and it'll bang right into the top of this little hook right here, and it won't let it come up in the air. Makes sense so far?
Yes.
All right. And I'm trying to do this in as layman terms as possible so that you can have a good understanding of it. And if you have a good understanding of it, then you kind of know why we're doing what we're doing. And if you know why we're doing what we're doing, then you'll do it. And then if you do it, you get better. Easy as that, right? All right. So when this rotator cuff is healthy, like I said, it helps you reach your arm up in the air, straight up in the air, or out to the side, or behind our back. It does all kinds of different movements, but the important thing is that all those muscles have to work together. Okay. All right. So, who am I, and why would you listen to this guy that's standing up here just because I have a fancy blue shirt on, right? So, basically, when I first got out of school 16 years ago, I was at a clinic and nobody wanted to work with the shoulder. So what did I do? I said, that's the thing that I want to work with. Nobody wants to work with it. So I started studying a little bit more and a little bit more. Some of the physicians that I worked with noticed that, and they kind of brought me underneath their wing. They taught me how to read radiographs. They taught me how to read MRIs. At the end of my workday and his workday, we would work out together, talk shop, figure out what was working, what wasn't working. So I had the opportunity to work hand in hand with one of the best shoulder surgeons in the Southeast, and some even think one of the best in the United States. So I had a great opportunity to be able to work with him. We wrote some papers together, and then we also wrote a book together, which you have right there, what you've been looking at. So he wrote the pathology side, fancy word for basically what's going on inside the shoulder and what he would do surgically, and then combined what I would do from a rehab perspective for that. So we put some timelines in there on what to expect, and then we also put some exercises in there on what we would do during those particular timelines. Now things change, obviously, so surgeries change and they become better over time, and so the rehab can either be sped up or sometimes it has to be slowed down depending upon the quality of the tissue too. So I wrote a shoulder book, I wrote a couple pages, a couple journal articles as well. So over time I've continued to get to work with other shoulder surgeons down here in Chattanooga and talk shop with them, work closely with them, and I think that really helps from a communication standpoint whenever the surgeons refer them over, whenever orthopedists or other doctors will send them over. As long as we're both on the same page, hey, this is what I'm seeing, hey, this is what I'm seeing over here, and we can kind of talk back and forth. I see you guys 2 to 3 times a week, and that really helps me communicate back to the doctor on the progressions and what's actually happening. And that's how we get such good results, because we stay in good communication. Okay, so that's why I'm up here. That's why I'm talking about this talking about the rotator cuff and the shoulder. So let's talk about this blue muscle first. On your paper, 3A, I've got it down there, and it's called the supraspinatus. So S-U-P-R-A, spinatus, S-P-I-N-A-T-U-S. If you have an Alexa, you'll have to ask her how to spell it and see if she spells it right. All right, so it originates from the top of the shoulder blade. So we kind of showed you that little spot right there on the shoulder blade. So it originates right here, coming right through here. Comes all the way over, actually kind of turns into tendon here, but comes over and inserts on the outside there. It's got really 2 little insertions here from a tendon standpoint. fancy words here, articular side and bursal side. Not important at all, but it has two little insertions right there. Not important for what we're talking about here. But again, it helps to keep this bone here, that humerus bone, centered inside this joint, right? So it helps to keep it right inside, right there, locked in there, right? So it's responsible for helping you to raise your arm in the air. It helps you raise your arm out to the side into this direction, and helps you raise your arm up overhead as well. And that's that person that you may see that does this right here if they have that particular type of tear, okay? All right, so whenever we have a shoulder problem and it tears, that is one of the most commonly torn of the rotator cuff muscles. 80 to 85% of the time, that's the one. That's the culprit. So it's a really high percentage right there.
Is it usually from tear and wear, or?
Wear and tear? Awesome question. That is a really good question. So, you were here for our lower back workshop, and, over time, the water starts coming out of the disc as we begin to age. So I use the analogy, just like the hair on some people's heads starts to thin out over time, so does that rotator cuff. If it's the muscles aren't working together properly, if it's the posture that we do nowadays, the posture that we do, we're driving, we're reading, now we're texting and our heads are down all the time, or we're on our iPads, or we're on our computers, that rounds those shoulders forward, that little hook that I talked about right here that comes over the top, and we start raising our arm up overhead, that rotator cuff just starts to bang inside of there over time. And as it starts to bang, it starts to fray and wear out. So, an excellent question. The one way that we do test that muscle, it's called the empty can test. Fancy, but I was going to take a water bottle, but it's just like we call it, you're good, it's just called an empty can, like we're going to pour that water bottle out. So we'll actually bring them kind of out here to the side, we'll turn it over into this direction, and then we'll ask them to put some resistance on it. We'll look with our eyes to see what's happening right here, if they start to hike up, or if they start to compensate in other ways. Then we know that supraspinatus is a weak muscle. Okay? So again, we're looking at our eyes to see the movements and the mechanics. Okay? All right, so the next muscle that we talk about here is that infraspinatus. So that's the one that I'm shading in right now. That's on the bottom part of that shoulder blade and comes over and attaches over here too. If I ever decide not to do this PT thing, I'm going to go into that art thing. So there's the infraspinatus. Okay, infra, we'll spell that out for you. I-N-F-R-A, spinatus. So it's below that piece of the scapula there. We call it the spine of the scapula. So it's just right below this line here. So it's right below that line right through there. Okay, so that's the infraspinatus. It's on the bottom 2/3 of the shoulder blade, and again inserts over here onto the outside of that shoulder bone, that humerus right there. Okay, and it is responsible for rotating the arm out to the side, out to this motion out here. Okay, if all the other muscles are working, we need to get it. It's responsible for this motion right here. Fancy word is called external rotation. So we're recording this for some people at home as well, so if anybody has any questions there, tell them to feel free to ask any questions on Facebook Live, and I'll try to get those answered too. All right, so it's responsible, like I said, for rotating the arm out to the side, and it is involved in rotator cuffs almost as frequently, but not quite as frequently as that supraspinatus up at the top. And then how do we test for it? So there's two different tests here. If we can't get them up into this position, sometimes I'll bring them here and then I'll put some resistance there and see how much strength they have back that way. Or I'll have them down here at the side, bring it out here, and I'll try to push in here and see how much strength that they have. Okay? So that's the infraspinatus. So we'll test that supra, and then we'll test that infraspinatus. So the third muscle that we have here is this teeny tiny little muscle, and it's the teres minor, coming through this way right here. So that's that small little muscle right there. And it originates again from the outer border of the shoulder blade and inserts into that outer tip out here. So again, it's on the back side, and it is actually going to work in tandem with that infraspinatus, the infra that we just talked about, in rotating the arm out to the side. Okay. So again, we kind of test that by doing this motion right here. And then we can bring you out to the side and test it as well. And we like to put our hands on it to make sure that we're testing for that right muscle and trying to feel it contract. Okay. Then finally, let's go to the red muscle here. And this is, again, we're looking at the front side here. And again, it's on that shoulder blade. Here's the little muscle fibers that come across. And it comes off the shoulder blade, again, attaches to that humerus, and attaches kind of on this front side right here. And it allows you to go into what's called internal rotation. So bringing your arm into this direction right here. Now, it's responsible for reaching behind your back. So we can do a specific test called a lift-off test. So we're here, and we want to see if that person can actually lift that arm off their back. Or we do something called a belly press test, where their hand is here, and then we try to create some resistance, and sometimes that can cause some pain as well if that subscapularis is involved. Okay? All right. So, any questions about that out there online or in here? All those muscles, we're on the same page? Let's write that word down there since we wrote all the other words down. Subscapularis. So if anybody's playing Scrabble tonight or tomorrow with Mom, now you got 4 words right there that you can score a lot of points on. All right, so the grading system for the rotator cuff tears. All right, so let's get in here. So we have, the first one is going to be what's called a grade 1. Pretty easy, right? So we go grade 1, we go grade 2, and we go grade 3. So only mild damage is done to this muscle or the tendon there, and less than about 5% or so of the fibers. So that causes minimal loss of strength and or motion. And these injuries will typically take about 2 to 3 weeks to improve. Sometimes they will improve on their own. Sometimes they won't. But with the right movements, then we can help to facilitate that healing, okay, with the right activities. All right, so grade 2, more extensive damage is done with the muscle or the tendon fibers, but it's not a complete rupture of the tendon. Oftentimes, in this particular case, you have a significant loss of strength or a significant loss in motion. I am struggling. But it may take 1 to 2 months or so to actually recover from this type of injury. But the right things need to be done in order to help that heal. Okay? The right movements and the right strengthening activities need to be done in the right order in order for that to heal. Okay? Then we have a grade 3, and that is a complete rupture of the tendon. The whole tendon falls off or comes unattached. These sometimes, I would say sometimes, I'm generalizing, but a majority of the time will need to have surgery. But sometimes people aren't necessarily surgical candidates. They may have other what's called comorbidities They may have heart problems. They may have really bad diabetes. They may have some really serious issues where they can't have surgery. So when I was in Knoxville working with the other doctor, we actually participated in a study called the MOON study. This isn't on your test, but MOON, Multi-Organizational Orthopedic Network. And it was with, we did it with Knoxville, we did it with Vanderbilt, we did it with Ohio State, Colorado. We were all over the United States, and we asked the question, why do some people that have rotator cuff tears, why do they have to have surgery, and why do some of them not have to have surgery? So what we did is we developed this protocol. You could use heat or ice. We did not use ultrasound at all. That was an old modality that was used a long time ago. There was no evidence that supported the use of ultrasound. So we did not use any ultrasound, but we used a specific program in order to help to see if we could A, gain all the range of motion back first, and then B, strengthen a certain group of muscles and a series of muscles, and then see if we were able to get them to be able to pop their arm, raise their arm back up in the air again. So that was a longitudinal study. You can probably Google it on the Google machine and look exactly on how we did that and exactly what we did, and it's out there. So that's a cool little study that we did when we were up there as well. So yes, a majority of people will need surgery if they can have surgery, but not necessarily. Again, it may be an older gentleman or an older female that have those comorbidities. So that's something that they go to their doctor, let their doctor know about that, and physical therapy is something that can help with that. Okay? All right, so the number one single biggest mistake, you've been here, you've heard it before. So the single biggest mistake is that they let that grade 2
ignore it.
Yes, exactly. So you let that grade 2 injury, or that grade 1 injury that never healed, you just continue to ignore it, and you keep doing the same thing over and over again. That's not the right solution, right? You do the math problem wrong, well, I'm going to then I keep doing it the same way, I'm never going to get that problem right. We got to try something else. We got to try a different approach. So the body doesn't necessarily heal on its own. We have to stimulate it to heal, thus a surgery. We don't necessarily fix it with the surgery. We put it in the right place, and we do the right things that help to stimulate healing. The same thing that we do here in physical therapy. We try to stimulate the healing process. We use biology to our advantage. Certain things happen within certain time frames. First set, 48, 72 hours, you go through that inflammatory phase. So there's certain things you do. And then the next 2 weeks, you do a certain group of things. And then you just keep progressing. But we have to assess and read the body language and read what the body is doing in order to make that happen. There's some psychology that happens along that way too, which is all very, very important. Okay? So, yeah, we don't want to ignore it, right? If you ignore something and you wait for it to heal, oftentimes you're 4 weeks later, 6 weeks later, 3 months later. I had somebody in here the other day that was 18 months later, and they were finally trying to do something about their pain. 18 months. Can you imagine living a year and a half with pain and not being able to raise your arm up? That makes my job a lot harder. And it makes it painful. And you lose time. And time is very valuable in this day and age. So people will they'll alter their body mechanics. They'll alter what they do around the house. I hear this all the time. Yeah, I've had shoulder pain for the last 18 months. So I'm like, so how did you put dishes away? They're like, oh, I didn't do it. I kept them on the counter, or I would make my husband do it. So that's just altering things. That's not really confronting it and absolutely handling it. So they changed what they were doing. And then that ultimately, if it is a complete tear or it is that partial tear, and they reach into the back of the car to get their purse, or I'm out there and I'm trying to start the lawnmower, and it's just that one straw that breaks that camel's back. It can be anything, right? So we don't want to ignore it. We don't want to alter or change our mechanics. I see it with back pain. People, instead of bending over that way, they'll come around. Well, that's the only way I can do it, is coming up that way. So got to be able to handle it. Got to be able to handle your issues. So how do we handle the rotator cuff tears and shoulder injuries? Well, we do a lot of hands-on therapy. We use our eyes, we use our brains to assess the way that things are moving. We get the range of motion back. In particular, another fancy word, it's called the posterior capsular mobility. We often lose that. We're in this position here. And just our daily life that we do here. We often lose the ability to go into this direction or into this direction here. So we look for very specific tests and very specific motions in order to be able to handle that posterior capsular mobility. Then we're in this rounded position here all day long. So we try to, again, do some more manual, some more hands-on activities to really open that chest up. There's a lot of work that we do on the pec minor. There's a lot of work we do on the neck that becomes forward. And so we have to work on stretching all this material, all these structures here. And then we'll even stretch this structure right back here. And then we do a lot of very specific strengthening for what's called your parascapular muscles, or the fancy word here is called a transverse. Another one, we're playing Scrabble again. Transverse force coupled. So when I drew these muscles up here, you have some of these muscles that work together. We want all these muscles to kind of work together here in a particular order. All right, so the transverse force couple, that's the muscle in the front and the muscle in the back. If one of them if these are weak back here and this one's too strong, it's going to rotate that into this direction here. So instead of it being even like that, and this muscle's strong in the front, those in the back are weak, it rotates it a little bit more this way. If you don't have that top muscle holding it here, then it elevates up because it's not holding it in place. Okay, and then, so that's for the rotator cuff, and then we have some for the parascapular muscles. That means the muscles around the shoulder blade, parascapular muscles, and that's really the inferior tract, the muscle that helps to hold your shoulder blade down here. And then another muscle called your serratus anterior. It's a fancy muscle that helps to bring your shoulder blade out to the side when you bring it into this range right through here. So it helps to pop that shoulder blade out so you don't get something, if anybody's heard of impingement, the shoulder gets impinged on that little hook right here. So we work on motion, we work on flexibility, we work on very specific strengthening exercises. And then it just really depends on how quickly and how fast that you want this thing to heal. But sometimes we can actually use a cold laser on it. So it's a class 4 laser. And basically what it does, it helps to stimulate and it helps to speed up the healing process on the cellular level. I could go into another hour-long talk on exactly what the deep tissue laser does. We have one at one of our clinics downtown, but it's an amazing tool that can help with pain, and then again help with healing on the cellular level, the mitochondrial level. And again, I could do a whole workshop on what that laser does. So again, we use range of motion, ROM, range of motion. We use strengthening and stabilizing. And then we get back into what I would call functional strengthening, making sure that you can do the things that you have to be able to do at home. If it is reaching overhead, if it is reaching out to the side, if you are an athlete and you have to learn how to throw again, I want to look at the whole entire body to make sure that all of that works together. You may be compensating in your shoulder because of something that's going on your opposite hip. If you're a thrower, or if you're at work, it could be that we need to address the way you're sitting at your workstation, at your computer. I get that all the time. A product that we actually offer to the Chattanooga area, me and one of our other therapists, we actually went to an office building and helped out, I guess it was about 10 to 12 people in that office, and you would be amazed at how some people have their computers set up. I mean, one lady, her monitor was over here and her desk was here and her keyboard was here, so she was doing this all day long. It was awesome. I was like, you're kidding, right? So we had to go in there and adjust, and there's specific things that we can do from a work chair standpoint, from a monitor standpoint, from where your keyboard is. A lot of different things that we can do to affect not only your shoulder or your neck, you were talking your upper traps, but also your low back and your hips. I talk to people all the time in here when they tell me I've got back pain, I've got hip pain, and I'm asking them, well, what do you do for work? And if they say I work at a computer all day, there's some go-to material that I go to and kind of show them how to set that up. So we definitely want to work on that workstation too. So I don't do this for everybody, but if I don't do this for everybody, I don't do it for the general public. I do it for people that are current patients of Summit or current friends and family members of patients that are coming to Summit. I'll actually do a free consultation for them about their shoulder. So if you or somebody you know and you're a current patient here at Summit Physical Therapy, then we can actually talk about doing a free consult for your shoulder. Okay. All right, so if anybody doesn't have any questions at this point in the game, I will be turning the floor over to this gentleman right here in the back, Nick, and he's going to be taking over from there for me. All right? All right, so if you got questions, let me know.